Good morning, and thank you for coming to our conference. I'm here to speak on management of recurrent and advanced thyroid cancer. I'm going to start with a case. We have a 48-year-old female, status post a total thyroidectomy for a T2NX right papillary thyroid cancer about 2 years ago. She now has an ultrasound finding of a 0.8 centimeter right level 4 lymph node. Pertinent labs include a suppressed thyroglobulin of 1 with negative antibodies. I would like to alert everyone to this great paper that was written by the American Thyroid Association Surgical Affairs Writing Task Force. It's called The Management of Recurrent or Persistent Nodal Disease in Patients with Differentiated Thyroid Cancer. There are a lot of great tables in here, which I will highlight a few of them. First of all, some selected recommendations in terms of what should be undergoing active surveillance versus surgery. The size of the lymph node is very important, and it differs between the central neck and the lateral neck. So those that are less than 0.8 centimeters in the central neck and those that are less than 1 centimeter in the lateral neck can be observed according to these guidelines. However, if there is a rate of growth of lymph nodes that it's greater than 3 or 5 millimeters per year, then the recommendations are to move forward with surgery. If there's proximity to or invasion to other vital structures, such as the trachea, esophagus, or recurrent laryngeal nerve, then one might recommend surgery as well. There are significant risks in reoperative surgeries, and this paper demonstrates how hypoparathyroidism and unexpected vocal cord paralysis can occur. This is why we need to be very careful and deliberate in those patients that we recommend surgery for. It's also important to identify what is persistence versus recurrence. Biochemical recurrence is that with a high thyroglobulin, but no structural correlation. And without a structural correlation, it is very difficult to advise on further treatment. So we tend to avoid surgery for biochemical elevations of the thyroglobulin without a structural finding. But it is important to also balance this with the patient's anxiety level. I'm going to move on now to well-differentiated thyroid cancer that's invasive. This paper comes out from the American Head and Neck Society, and it's a consensus statement. So what about advanced thyroid cancer? Thyroid is the organ is near the recurrent laryngeal nerves, near the trachea, esophagus, and the larynx. And these are the areas that I'm going to highlight this morning. So first, the recurrent laryngeal nerve involvement. The big conundrum is whether to resect or to preserve the nerve. For those that are in favor of saving the nerve, there are problems with local recurrence and also with differences in survival. So for those that are in favor of resecting the nerve, the feeling is that there's a higher local recurrence rate with gross residual disease. Therefore, it seems prudent to resect the nerve if that is required to remove the mass. However, there hasn't been found to be any difference in survival. Therefore, there's some caution in resecting the nerve. If we do elect to resect the nerve, it's very important to reanastomose and provide a nerve graft so that the nerve can remain in continuity. That integrity can allow for some tone to that vocal fold. So here's an example of the nerve. You can see the recurrent laryngeal nerve here, and then the tumor. And these are slides that I'm sharing with permission from Dr. Maisie Shindo. And here's the proximal nerve. The tumor is ballooning out this nerve, and there's really very difficult to save this nerve without compromising cancer control. So next, we're going to talk about tracheal invasion. Here's the trachea on a cross-sectional CT. The tumor is intimately involved with the trachea, and you can see the lumen has been somewhat violated as well. Here it is here, and you can see that the the round shape of the trachea has been malformed so that there is suspicion of invasion of the tracheal wall. And here is an endoscopic view of the trachea. You can see here the tracheal rings, and on this left side there are exophytic masses, and this is all tumor that's invaded directly through the tracheal wall. So the way to do this is to try to resect the trachea. This is not an example of cancer being removed with a tracheal resection. However, the principles of the surgery are consistent. So what we do is we cut the tracheal ring, we put the endotracheal tube into the distal portion of the trachea, and then we reanastomose the two ends together so that the part with the cancer has been removed. Whether to shave or resect is also another decision point for the surgeon. There is a higher recurrence with a shave, and if you recall the last picture with the intraluminal involvement, a shave really would not work at all. There is a higher morbidity with resection of the trachea because of the potential for tracheal rupture or a leak from that area. Esophageal invasion. You can see here that there's probably some esophageal invasion in the posterior aspect of the esophagus. Oftentimes, this can be removed without invasion into the esophageal lumen. It's usually the muscles overlying the esophagus that's involved. So I like to consider, I like to place a Maloney dilator to give the esophagus some integrity and making it difficult, making it more easy to carefully dissect the mass off the esophagus. It's important to resect the muscularis layer. And if there is interluminal invasion, it's very important to do a primary closure or a tissue or flap closure over it so that there's not a leak. The last specific concern I'd like to touch on is laryngeal invasion. And this is a video of someone who's had a laryngectomy.
Friends from this country, let me hear you. I come not to praise these, or I come to belly for thee. Emory got 10-987-654-221. And this stands free and it's working really good for me. Today, I hope it works just as good tomorrow.
So the reason why I share this video is so that one can realize that having a laryngectomy isn't a death sentence. People can recuperate much of their functional status, including their voice, with proper rehabilitation. And potential complications for these types of surgeries can be affecting the cranial nerves, including cranial nerve 11, a hematoma, a chylous fistula, wound complications, carotid rupture, thankfully, is very uncommon, and of course the tracheal and esophageal tears. So here's some examples of a cranial nerve 11 injury. You can see the winging of the scapula and the drooping of the shoulder. And then cranial nerve 12 with deviation of the tongue towards the side of the pathology. So in this example, the left cranial nerve 12 has been afflicted. A chyle leak, it can happen, particularly when we're trying to chase after these lymph nodes that are very low in the neck. And thyroid cancer lymph nodes like to live down here around the junction of the internal jugular vein and the subclavian vein, particularly on the left side of the neck. The thyroid would be resting here, and these are the lymph nodes. So the thoracic duct tends to come up through this area. It's very close to where the internal jugular vein joins up with the subclavian vein, and therefore a lot of care needs to be taken to be sure that these branches are tied or clipped in order to control it. Otherwise, you'll end up with a chyle leak. And my last few slides emphasize the need for multidisciplinary approach. It's very important to involve the patient and the family members. Every month we get together as a group to discuss our cases. We value each other's input and we learn a lot from each other. So we have endocrinology colleagues, radiology, medical and radiation oncology colleagues, and pathology as well, to go over some of these more difficult cases and determine what is the next best step in their treatment. So the good physician treats the disease and the great physician treats the patient who has the disease. So for both of these guidelines, they are just merely guidelines. So each patient must be weighed independently. However, I think these two papers outline a good framework by which we can make our decisions and offer evidence to support how we treat our patients. Thank you.